about the opioid epidemic. So what do you know about it? Don't lots about it?
Maybe being scared. Is it locked? I think someone's trying to be scared.
Who is it?
Do you guys know something I don't know?
I think
I bet it's McNeil. Oh, that's right. Well,
Yeah, it's probably weird. That's scary. Okay. So what do you know about the opioid?
Hello, everyone. Daddy's packing today.
Did you come in late on purpose?
Yeah. You know
Anybody else?
I just opened them.
Have you gone upstairs
Oh,
yet?
yeah, I'm going to.
Has he seen you yet?
No. Should I go now or later?
Have her call him.
So,
Oh, gosh, okay. That's good. All right. Third time. What do you know about the opioid? Called a national emergency. Why is that?
no, he didn't.
Pardon?
I thought he didn't call it a national emergency. And that was the big hoopla, right?
Sorry.
Number
Number of deaths,
Oh.
okay.
And then eventually, John McCain was like,
That was like the whole headline.
Okay, so she says OxyContin most commonly abused drug. What else do you know?
If you bend your needles, that means you have a like disease and not to use the needle anymore. They'll leave the syringes around the parks, and the ones that are bent shouldn't be picked up. I saw that on the news.
Really?
Yes.
Okay, hadn't heard that. So
I hadn't either.
leave up- so leave
Well, I
up.
mean, it's nice that they're bending them, so you won't.
Okay,
There's an alternative.
so all you do is take pliers and bend them.
People get hooked with the prescription stuff and then they switch over to heroin, things like that, because they're cheaper and easy to get, and that's where it's not as standardized, so people get in trouble with the overdose of that too.
So that's true, what he says. Did you hear, could you hear on the back row what he said? Turn around and say it to your class. Because you have so much credibility.
Yeah, so I was saying that people get hooked on the prescription stuff, but then it's hard to get that sometimes, and so they switch over to things like heroin and other more illicit opiates to meet the need, but they're not, that street drug is not as standardized, so then they get in trouble because they don't get the same dose every time, they end up with overdoses.
Mostly true, yes.
Patients get addicted very easily, and it's also a lot easier to overdose on opioids because they're in this constant pain, and so they just keep taking it. That's what I think causes them to become addicted to it.
Probably to some extent, yes.
Well, I worked in a position who did pain management, and we started talking about how the patients were, not our patients, but the heard of patients, buying hydrocodone from Mexico that had been made with fentanyl in it. So they were buying what they thought was just hydrocodone and crushing it up and injecting it, and they were overdosing and dying quickly because they didn't know all of what was in the drug.
Very true.
This is kind of a question, I just read this, you might be able to answer this, but I read, I think this week, that fentanyl was more than half of the overdoses were responsible. I mean, it was responsible for more than half the overdoses right now.
Yes, that's exactly right. So most of the problem is due to illicit fentanyl. It's not the prescription drugs. They've jumped on this bandwagon to some extent because people will move from prescription pain medicines to more illicit. So heroin, how is heroin linked to other opioids? What is it very close to or akin to? Morphine. Okay. So it's it can be a cheap morphine, so that's not an uncommon transition. Okay, let me give you some facts. Let's kind of go through these. This is I'm going to test you on this information. I just want to set the stage for you. So drug overdoses have tripled from 1999 to 2014. So in 15 years, they've gone up threefold. So I told you that overdose deaths had overtaken motor vehicle accidents as the #1 injury related deaths. So 52,000 in 2015, where there's mostly complete data. 63% of those are opioid use. The death rate involving heroin and synthetic opioids, so that's illicit fentanyl for the most part, are primarily responsible. Most of that illicit fentanyl comes from Mexico and China. 2014 to 2015 death rates from synthetic opioids increased by 72%. This is not the first time in history. If you look back in the 60s, there was a spike in illicit fentanyl or illicit drug use that led to the deaths. So, and they shut them down and then they pop back up. So Wichita, who's from Wichita? What's the man? Kansas, Abby. Okay. So Walter White, you know who Walter White is? Okay. So there was a man from Wichita who was called, now they call him the Walter White of Wichita, because he was an expert at producing illicit fentanyl. He was a genius. And I read a quote about him, or somebody went to high school with him and said, I always knew he'd either win a Nobel Prize or he'd go to prison. Well, he ended up going to prison. He was brilliant, and he was responsible for probably 25 to 30 years ago, a lot of the illicit fentanyl in this country. So you'll see spikes of it, where people can manufacture it, sell it to dealers, then they can use it and cut it with whatever they're going to usually cut it with, usually heroin in this country, and sell it. You look at natural and semi-synthetic opioid deaths, that's prescription, that's 2.6. So when they talk about the opioid epidemic, it's mostly illicit drug, it's not the prescription drugs. But they're all getting on the bandwagon of the manufacturers about how bad they are. Well, they're not really the bad players in this, it's the people who are manufacturing illicit drugs and then putting it on the street. So just to remind you, natural opioids are considered morphine, and codeine are considered natural opioids. The semi-synthetic would be like hydrocodone, oxycodone, hydromorphone, oxymorphone. So you mentioned OxyContin, that falls in this category. So these are mostly your Schedule 2s and 3s. Synthetic opioids are methadone, tramadol, fentanyl. Illicit opioids would then be heroin, would be an example. So drug overdoses in 2016, this is for the last 6 months, July to December. Estimated in the whole year, greater than 60,000 drug overdose deaths. Fivefold increase due to synthetic opioids, it's that illicit fentanyl. So in 2013, it was 3,000 deaths, 2016, 20,000 deaths. This is to the rise of that illicit fentanyl coming out on the market. Primary reason is the fentanyl. It is detected in over 50% of overdose deaths. It has 3 conjugates or 3 metabolites or analogs that are very similar to fentanyl. Those are hard to pick up. So that's one thing that the drug people who produce illicit drugs look for is, can you produce a conjugate that it can't be detected? So that is also adding to the overdose rates. Let's see. Fentanyl detected at least 50% of overdose deaths in 7 states. It tends to concentrate in the United States. It's different on the east of the Mississippi, different in the west of Mississippi. I'll show you some of that data. 57% of fentanyl overdose deaths also tested positive for other illicit drugs. Heroin, #1 cause, or the #1 drug that they use to mix with fentanyl. The other is methamphetamine. And the type of heroin they mix will differ depending on what part of the country you're in. So fentanyl, what makes it so deadly is that it is so potent, 50 to 100 times more potent than morphine. Let's see, east of the Mississippi, they cut it with what they called white powder heroin. West of the Mississippi, they cut it with black heroin, which is a very sticky substance. that is just one of the forms of heroin. The analogs are very similar to fentanyl. There's 3 of them. The carfentanil is probably the most problematic, causes the most deaths of the analogs of phenytoin. You can see very, very potent. Used in, what I understand is in cattle for not analgesic, I guess analgesic. Kendall, have you ever heard of that? Okay. Fentanyl deaths in a 10-state, and we are a part of that. There is a group that is put together, a coalition that was put together by the CDC that monitors in these 10 states, Oklahoma being one of them, opioid deaths, probably because of our link to methamphetamine use. So 53% of the 5,000 plus opioid deaths were due to that, had fentanyl as part of it. You'll see Oklahoma and New Mexico are one of the lowest in terms of these deaths, but we border states that tend to be high. Missouri tends to have a very high opioid deaths, and so we border that, we border New Mexico, so it kind of gives us some of it. Others would be Massachusetts, Maine, Ohio, Illinois are very big also. Demographics of people who die of fentanyl overdose, predominantly male, predominantly white, and young in the 25 to 44 year age. Co-ingested drugs. One thing I want you to always take away from at least these lectures on overdoses is that most of the time overdoses are multiple. In kids, and this is just my experience, in kids it's usually one drug, they got into one thing, but in adults it seems like when I was in Austin and I did a lot of PR work in my residency and as a PharmD student, is that they just, if they were intending to try to harm themselves or cause major damage, they just took the medicine cabinet. So there might be one predominant drug, but they often had others with them, alcohol or Tylenol, aspirin, whatever else was in their cabinet. So co-ingested drugs, cocaine, heroin, methamphetamine, more common in this state. Others, heroin, usually overall most common. Route of administration. So often the route of administration is often not, they can't detect it. But with fentanyl, it's usually snorting or taking it orally. IV or injecting it is also common. The smoking, less common. Transdermal usually relates to pharmaceuticals. So they've gotten the fentanyl patch somewhere. Stole it, bought it. No evidence of any route by 35%. So here are the 10 states. It just shows you in light blue is fentanyl overdose deaths. The analog is in the darker blue. So you see in our state, it's much less for the analogs, much more for the fentanyl. If you look at Ohio, it's one of the highest, in Maine for also the analogs. So this just came out from the CDC on Monday, so I wanted to share it with you. Questions about those? Puts it in perspective. So when you listen to that epidemic, it's illicit drug. It's not prescription, but I don't think they make that very plain. I think they mostly are putting the biggest onus and the bad guy here is the prescription drugs. It is not. But like Ron said, it is often a prelude. People often have used prescription drugs before they get to those others, but not necessarily all the time. Okay, so let's look at on your handout from last week. Pick up on page 24. So classic signs of opioid intoxication. So mostly CNS depression and respiratory depression. So the respiratory depression is what usually is going to be the higher mortality rate. So mental status change, respiratory rate change, tidal volume change, vowel sounds, and then miotic pupils. But if they have co-ingested with other products, the eyes are not always will relate or will stay true to this. If they've taken drugs that will dilate the pupils, that may be predominant, or they may be normal. Best predictor of an opioid poisoning is a low respiratory rate. In fact, when we treat, we're treating towards that. Our goal is to increase ventilatory support. So the physical exam findings are in that table. So heart rate can go up or down. Again, it'll depend on what else they took with it. Blood pressure, again, can go down or be normal. Respiratory rate always goes down. Temperature change, again, can decrease or stay the same. Vowel sounds, you know that it's going to decrease peristalsis, so their vowel sounds are going to be diminished. Neurologic, they can go anywhere from mild sedation to profound coma. In seizures, particularly if they've taken Demerol or meperidine, is common. Ripoxafine's not on the market anymore. I don't know that there would be any way to get a hold of it. Tramadol would be another. And then the eye changes would be the miotic appearance. Questions about those? Yes?
If they go ingest something like a methamphetamine with that, would that, do you change that? I mean, would the heart rate need to be increased?
Probably depending on the amount, yes, very much so.
Maybe depend on which drug was the most.
Yes, depend on what drug is the predominant. The one thing with illicit fentanyl is that it causes a decline in function extremely quickly. One of its monikers on the street is drop dead, which is very telling because it can quickly kill people. So sometimes rescue is not possible because of the onset and the potency of it is so high and so fast. So under physical exam, we talked about respiratory rate going down, so pulse oximetry would be important. Hypercapnia is going to be usually a predominant. Heart rate normal to low, we talked about that. Blood pressure, some of these drugs will cause histamine release. Meperidine is one of those, so they might be hypotensive because of that. And then hypothermic, depends on if they've been out in the elements, how much their thermogenesis or ability to regulate their own internal temperature has been disturbed by the drug. Let's see, most of these I've hit. The other would be head trauma. If they hit their head when they're going down or they've been assaulted, and that is part of it. Looking at the skin for tracks, especially antecubital fossa is usually a more commonplace. And then pulmonary findings, they could aspirate if they were ingesting something at the time, or they have vomited. They could also aspirate stomach contents. Toxicities of specific agents. Be sure you look at these because they're really different. Some of them we have talked about as these drugs have come up. Bupropion has an antagonist quality, so you can see actually symptoms of opioid withdrawal with that drug, in addition to opioid overdose findings. Dextromethorphan we talked about with cough and cold, some other place too. Oh, with serotonin syndrome. So that drug has serotonergic activity, so you can see serotonin syndrome with large doses of dextromethorphan. Loperamide, we talked about when we did GI. That can cause a QRS widening in tachycardia. Loperidine, always think seizures. You can see it even with higher or normal doses. Methadone, QTC prolongation, torsades. Methadone is highly regulated, and the deaths due to methadone overdose have gone down by about 10%. So that drug is not contributing as much to overdose situations. Oxycodone, Samantha brought that up. QT prolongation is the problem. Also, when you think about prescription drug overdose, you have to think about Tylenol and aspirin, because they are commonly prescribed together, okay? So you would want to get levels, especially acetaminophen levels when you're dealing with those drugs. And then tramadol, also seizures, also has some serotonergic activity as well. So lab test, blood sugars, acetaminophen level, creatinine, phosphokinase, especially if they have fallen and been down for a while. They may have muscle breakdown that would lead to renal insufficiency. EKGs based on the toxicities we've talked about, and then a chest x-ray for possible aspiration or ARDS. Okay, so management, again, supportive activities for their airway and their breathing and their circulation, blood pressure. But naloxone, which you're probably familiar with, is a opioid antagonist. It binds to the receptor, it's a competitive antagonist, and just sits there and doesn't allow the opioid to interact. The amount of naloxone you give, and this is what I want you to appreciate, is dependent on respiration. So you'll see a gradual increase from mild sedation up to people who are in full cardiac arrest as to the amount you give. The more they're respiratory depressed, the higher the dose you give. And naloxone comes in multiple different forms. So it can come in a nasal spray, it can come in a solution for IV use. Those are the two I'm most familiar with. Oh, to give it sub-Q or IM. IV is preferred, get it in the fastest. Let's see, those of you that worked at EMT, did you all carry it? So in this state, EMTs can give it, and they usually carry nasal with them. Did you all, Andrew? Naloxone? Did you carry it on your, really? Lonnie, you all did? Okay. What'd you do when you got into an overdose situation? Call for help. Okay. Some of the, is that just state specific? Was that just California?
Pretty restricted in our scope.
I wonder if that has changed, because they keep broadening that scope, especially for different levels. But I think all levels of EMT can or paramedic can carry it in Oklahoma.
I think probably medics, not yet.
Ah, I see, medics. Sorry, that is my ignorance of those levels when I use those words. I'm using them interchangeably, but to you that means something specific. Okay. Okay, so if you look down, so it isn't, you're not trying to return them to normal consciousness, you are trying to raise their respiratory rate, and that's your goal, is the respirations and not their level of consciousness. You don't have to worry about giving too much. You can't overdose them with naloxone, but you can give them enough that you can precipitate withdrawal. And so if withdrawal occurs, it's just supportive type activity. So anxiety, agitation, restlessness, runny nose, lacrimation, those kinds of things are these symptoms of withdrawal. So it's a safe drug in terms that it has a wide safety, very little adverse effect. So I want you to know those dosings. I want you to appreciate that there is a range of dose based on respiration rate. Okay, GI contamination. This is one of the situations where you would never use activated charcoal because you've got somebody who is either not conscious or likely to be unconscious, and you would not want to do that due to aspiration, just the ability to get down the drug. Some other specific therapies for different types of toxicities, be aware of those. So for loperamide, using sodium bicarb. Sodium bicarb will help with a lot of arrhythmias, and we're going to see that when we talk about TCAs in particular. Remember, when you have malignant arrhythmias, the one thing to look at is magnesium, and also correcting any potassium in calcium. So that should be a recurrent theme that you should be hearing. We talked about it with the antiarrhythmics. We've talked about it in other overdose situations. Fentanyl, we're going to use the naloxone. So these folks often can be managed in a emergency room situation. So once you have, you've treated them with naloxone and they have stayed stable, and you haven't had to give any naloxone in 2 to 3 hours, they can be discharged. Probably with some type of follow-up and some type of social consult to address their drug abuse. Questions about those? Comments? Okay, so did Scott talk about bystander naloxone? Okay, so you can go into any pharmacy and get naloxone. You can also go to mental health facilities and get naloxone. Fill out paperwork, and you can get it if you are in situations where you have family members, or you are in situations where you think you are likely to come into contact with people who are could have opioid intoxication. You can get it without a prescription. You can get nasal, is what I think is available in Oklahoma City. Those of you, Sophie, or
I
did you
never
all do
gave it out.
Walgreens? Really?
Never.
My apologies, what was this for?
Naloxone.
I remember hearing a conversation about our pharmacist trying to sell one to a patient, but our pharmacist wanted to see the patient. So there was a caregiver who wanted to come in and get it for someone, just to have on hand. But it seemed kind of weird. I don't know, is there addictive potential to naloxone?
No,
I
not
don't think
good.
that's
She was reluctant to do it without speaking with the patient, so, but yeah, I've seen them a couple of times.
I don't know that there is any, in the regulations, at least what I've read, there is nothing that says it has to be to the patient. It's mostly for people, caregivers, friends, families, people who are around it that can get it. The one thing, though, that it does require is teaching, at least teaching somebody how to use it appropriately.
That may have been more than what it was, because it was more of a caregiver than it was a parent. So I think she wanted to know a little more about why she was dispensing this medication. But yeah, I've heard of it several times, and I think I even saw it sold once or twice.
Yeah, they're about, from what I've read, it's about $80 to $100 for naloxone. Okay, so in places where they have used these programs, it has cut the death rate. So it's one to keep in mind as you come across patients or caregivers or friends, family, then know that at least in this state you can do that. And most states have some provision for people to be able to get naloxone to use in that situation. Questions about opioid intoxication? Okay. Then let's switch over to salicylates and TCAs. Okay, so what do you remember about aspirin overdose? It's bad. They can get very acidotic, it can get an amount of metabolic acidosis. What else? This used to be really common. When I was a resident back in the 80s, we saw it quite a bit. Saw it in kids, saw it sometimes in adults. But when the recommendations not to give aspirin to kids because of Reye syndrome, it dropped for a while. And so it kind of became less common. But it is on the rise. When I was talking to Scott just to find out what they were seeing, it's more of a problem. So it's one to keep in mind because it's very lethal. And for kids, it doesn't take a lot of aspirin in order to make them have a severe overdose or to die. Okay. So where do sources of aspirin come from? Pardon?
Everything.
Okay, what do you mean by that?
That it's, I guess I'm pretty knowledge and everything, but
Whatever.
Or-
Wintergreen?
Or oil of wintergreen. So a lot of people who like essential oils, that is a potential source. The problem with oil of wintergreen is it is extremely toxic. Very small amounts will kill children and can certainly make an adult very sick. So like, when I talk about small amounts, I'm talking like 3 or 4 mils. What else?
Icy hot, is there something about icy hot?
Okay, so topicals, you can put enough topical on to get salicylism, which is a high salicylic acid level.
Talk about kids eating it.
Oh, yeah, okay, yes, that's possible. For adults, you can put on enough. Think about the wart removers, facial cleansers, all have salicylic acid in it. Keratolytics are usually salicylic acid. Where else? Where's the big one I told you that people don't always think about? In GI, what do we talk about? Pepto-Bismol. I have seen overdose come in through the emergency room due to chronic Pepto-Bismol intake over short periods of time. All right. So they're listed there for you. Aspirin, so enteric-coated, baby aspirin, regular aspirin. So a lot of your grandparents are going to have aspirin around. And those are going to be over the counter. They do come in childproof caps as long as people keep them on there. So kinetics, let's look at this. So we've learned, you should by now be able to say the kinetics of a drug change when in an overdose situation. So usually absorption slows down just because the amount of drug. Metabolism usually slows down. Excretion usually slows down. Everything is overwhelming a system, so they can't get rid of it. They can't either metabolize it to something inactive, or they can't get rid of the active or the metabolites through the kidneys fast enough. So at therapeutic doses with aspirin, it's rapidly absorbed, and it is highly protein bound, which becomes a problem because the more you put into a system, you saturate binding sites, and so when you saturate binding sites, what's the ultimate, what happens from there? Why is binding important? Why do we care about it? Why?
You have to bind to exhibit an effect.
Pardon?
You typically have to bind to exhibit an effect.
No, you have to have free drug to have an effect.
Oh, you're talking about to like protein carriers? Or like cell receptors?
So if you got both. So protein binding is usually going to be to albumin or a serum protein. Okay? So in aspirin's case, it's greater than 90%. Anytime a drug is bound more than 90%, we consider it highly protein bound. Okay? So that means about 10% of it is in equilibrium with the free amount of drug in the blood. This is the amount of drug that can then interact with cells. So if you saturate, if you put a whole lot of drug into a system, you tie up all the binding sites. Okay. So the amount of free goes up. So the amount of drug that can interact with a cell goes up. Okay. So that's the significance of protein binding in this case. Metabolized by the liver, you can overwhelm those pathways, and so the amount of drug that is free to exert a toxic effect goes up. And then the kidneys are involved because they get rid of aspirin. If you think back to gout, we talked a lot about gout, aspirin elimination with gout. So an overdose situation, absorption is slowed down, may be delayed. A lot of times aspirin is taken as an enteric-coated product because it's hard on the stomach. So where do we want it to then dissolve? If it doesn't dissolve in the stomach, where's it going to dissolve?
Small intestine.
Small intestine. So once it gets there, then it has to degrade. The shell has to dissolve, and then the drug gets absorbed. So if they take an enteric-coated product, then things may be slowed down quite a bit. Talked about liver elimination is dependent on the kidneys, but some of the kidneys get damaged in this process, so that can lead to a decrease in excretion. Half-life can go from 2 hours to 30 hours. So the peak effect may be delayed, and the duration of the toxicity will also be delayed. Toxic symptoms usually occur once you get above a level of 40 milligrams per deciliter. Fatal ingestion in adults is 10 to 30 grams, that's a lot. So think about most of the time people are taking a 5-grain or 325 milligram tablet, maybe twice a day or 2 of those a day. That's 650 milligrams. So it takes a lot with an adult, but look for children. As little as 3 grams. That's 37 baby aspirin. Sounds like a lot, but they're tiny, doesn't take a lot. For Pepto-Bismol has, what does it say, 8.7 milligrams of salicylic acid per mil. So the usual dose is about 30 mils. That's 250 milligrams. So it takes about 360 mils for a child. It's not a lot, it's a 12-ounce bottle. So chronically dosing them over a short period of time can lead to salicylism. So usually people will use the term aspirin and salicylic acid interchangeably. Okay? Salicylism is the symptoms of high salicylic acid in the blood. So those are, there's where you see Scott Schaefer's slides over there to the side. Okay, so onset of symptoms, in an acute ingestion, it's usually quick, unless they've taken a whole lot or you've got mostly enteric-coated products, then you may be delayed. So with vital signs, these are important, so note these. So increased respiratory rate and depth. Okay. Salicylates stimulate the medullary center, and so rates go up initially. We'll sustain that by increasing CO2 production a little bit later. They also hyperventilate, so that not only are they tachypnic, but their ventilation is deep and somewhat like Kussmaul. So it isn't usually a shallow breathing, it's depth. So those are important. That's different than most of the time how people will present. Their temperature will usually go up. It's usually more significant in kids. Aspirin couples oxidative phosphorylation, so you get a lot of heat release, and so that accounts for the temperature. And then tachycardia, not sure why it does early on, maybe agitation, anxiety, volume loss becomes a problem as the toxicity progresses, and so that contributes in later. Tinnitus is very common, but tinnitus can occur even at normal levels or range. But this is a more classic. There's very few drugs that do this, so pay attention if people complain about that ringing in the ears. Next page, nausea and vomiting, early symptom. Aspirin is hard on the stomach, so people often go to vomit or complain about a lot of gastric distress if they've taken it. The vomiting can be severe, so the vomiting is important in that it can lead to volume loss. So paying attention to that, controlling that, getting the drug out is important. Acute bleeds are not very common. Significant blood loss, not common. Acid-base abnormalities, you get an increase in respiration, leads to a decrease initially of CO2 content, or of, partial pressure of CO2. So they'll get a early on respiratory alkalosis. They eventually develop an anion gap metabolic acidosis. We're going to go through that in the next section. So adults, you can see mixed. You can see both of those. Or you may see one, depends on how early in the toxicity you evaluate the patient. So you may see the respiratory alkalosis, but most of the time, by the time you see them, they'll also have a metabolic acidosis as well. So there's an altered mental status. This is important. One is a direct toxicity of aspirin to the brain. In an acidosis situation, most of the drug is going to be in an unchanged form, so it will move into the brain easily. The other is that glucose levels in the brain fall even though the serum concentrations stay normal. So you can get a neuroglycopenia in the brain, which can also lead to altered mental status. And the other is cerebral edema, which can occur late due to fluid shifts and a swelling of the brain. Seizures can occur, they're usually late, less common. You can also get pulmonary edema, again, probably due to vascular leakiness. You are disrupting and knocking out prostaglandins. So remember, we have prostaglandins that do a lot of local regulation. They regulate vascular flow in a specific area of the body. When you knock those out, you knock out the control. You also get an increase in bradykinins and other cytokines, which make those vascular membranes more leaky. And so you have fluid leaving the vascular space. In two places it shows up, brain and in the lungs. So it's not a cardiac, it's a non-cardiac pulmonary edema. Questions about those? Let's look at that. You know, polar substances cannot move through a cell membrane easily. You have to have an uncharged molecule to be able to move through a lipid layer of the cell membrane. So in an acidic situation, salicylic acid is a weak acid. What does that mean? What's a weak acid?
Doesn't like to give up its hydrogen.
Does not like to give up its hydrogen ions. Okay, so okay, so salicylic acid will stay in this state where it is in its dissociative form, charged, or its uncharged form. This is what moves into the brain. Okay. So if we can keep it in this form, it won't do that. So when you have an acid, so you've added an acid to a system, here's your blood buffer. So an acid does what? Which way does it shift this line right here? Look up. You guys are looking at your screens. What does it do? You add an acid, what happens? Which way is it going to go? I'm pouring acid in. How's it going to go?
Right.
What's the body going to do? It's going to increase respirations, right? So that's where your increased respirations come from. Okay. So one of the things we're going to try to do is we're going to try to reverse that acidosis by giving a bicarb. A couple of things that will do is if we put bicarb in, what's going to happen? Which way is the system going to go now? That way. Which way will this system go? If I put bicarb into this, what's going to happen? What will the bicarb do?
Neutralize.
It will tie up the acid. they'll consume the hydrogen ions, right? So which way will this go?
Yeah.
Major treatment in aspirin overdose is alkalization of the blood in the urine, okay? Because if we can do that, we can trap it in the kidneys, or we can keep it moving this way, so there's less uncharged to move into the brain. Okay, got that? Okay. On page 4, so you're going to get salicylate serum concentration. Here you're going to usually repeat it multiple times so that you can see that it is moving down from its peak, that you're getting a decrease or a response. Look for levels of high levels and other reasons to consider dialysis. So if you have somebody who comes in a really severe aspirin overdose, you need to have nephrology alerted because you may need to dialyze them. So this gives you one criteria is if their blood levels are over 100, that's an indication for dialysis. You can't give them enough bicarb, you can't do enough to get the kidneys to get rid of the drug, keep it out of the brain, so you have to dialyze them. Renal failure or renal insufficiency that continues to drop is also another reason to dialyze them. You get vasoconstriction in the kidney, and that leads to that acute renal failure. Again, you're knocking out those vasodilatory prostaglandins that are then changing blood flow, and so you end up with shutting down glomerular filtration. Potassium. If hypokalemia exists, it must be aggressively treated. What did you learn from Dr. Perry about potassium in an acidotic situation?
It moves into the cell or out of the cell.
Pardon?
Moves into the cell, doesn't it?
So in an acidosis, in terms of the cell, where did the hydrogen ions go?
In the vascular space, or potassium moving itself.
You increase hydrogen ion concentrations, they're going to go in, right? To maintain neutrality, potassium will get kicked out. Then potassium gets eliminated by the kidneys. What did he tell you? If you have a person comes in a DKA and their potassium level is normal, what do?
Fluid.
You give them potassium because a low potassium, a normal to low potassium in the face of an acidosis represents a big loss. It represents about a 10 to 20% loss of total potassium stores. And most of the time, by the time you will see DKA, a lot of those people have lost significant. So a normal potassium represents probably at least a 10% loss. A hypokalemia represents about a 20% loss. Did he make that point?
He said if it was less than 5.3, you would give them potassium. So a little lower in the, I mean, ultimately, I think less than 5.
The guidelines say that if they're around 5, you can start insulin, because when you start insulin, potassium goes into the cell. Okay. So the recommendations, at least by the guidelines, are if you're in 4 to 5 and you've got renal function that have urine output, you can go ahead and start insulin. If they are normal to low, you need to replace the potassium first, then start insulin. Does that sound like what he said? Okay. All right, so hypokalemia, you got to look at the acid-base status and figure out what do you need to do. Because if you don't replace it, it makes, one, the alkalization doesn't work as well, and the other is that you put them at risk for cardiac arrhythmias. Okay, once I'll take a break. We'll come back a little bit after 10.